Today, I will have the pleasure to share with you some data regarding, laser in prostate surgery and how did it take place as a new, I think, gold standard for prostate surgery. So let's see how it goes. This is some just epidemiological data regarding BPH burden. And regarding age at incidence, in the US, BPH trend tends to be diagnosed at a younger age. And this is largely due to earlier screening, higher symptoms awareness, and lower threshold for medical evaluation. And in Europe, diagnosis is more often delayed and symptom-driven, with patients presenting at an older age. BPH burden, as you can see on the right side of the right part of the slide, the overall BPH burden is increasing in the United States with a positive estimated annual percentage change reflecting rising prevalence, prolonged medical therapy, and longer disease burden duration. And in Europe, the burden appeared more stable and heterogeneous, and with several regions showing plateauing or declining trends. And these result in a higher cumulative disease burden in the United States, while Europe tends to manage fewer patients, but often with a more advanced obstruction at the time of intervention. Okay, so when I first started my urological practice, the therapeutic pathway was quite straightforward. So we essentially relied on alpha blockers therapy together or not with the 5-ARIS. And if medical therapy failed, patient proceed to surgery. So what was quite easy? The choice was QRP for most of the cases or open simple prostatectomy for larger glands. And this historical slide is a tribute to pioneers of BPH surgery. So Maximilian Stern introduced the first resectoscope, and Theodore Davis in the middle of the slide later developed the foot pedal system that gave rise to the modern concept of QRP. And since those early innovation, QRP has remained the gold standard surgical treatment for BPH all the way up to the present day. So before to move forward, I have some questions for the audience. So how many of you still perform QRP? Most of the people in the audience. And how many of you perform MIST? Just 2, 3, 4, just few. That's interesting. What about aquablation? 4, 5, 6. And what about laser enucleation? Just few. So QRP in this audience is the main procedures for surgery. So that's why. I think because QRP is supported still by high quality evidence in literature, and which allows the procedures to be strongly recommended. This is the European guidelines, and it is recommended for prostate in the range of 30 up to 80 millimeters. And American guidelines are a little bit more permissive in indicating QRP broadly for lots related to BPH without strict prostate size thresholds, and QRP is still considered an acceptable standard option in the United States, with the choice between monopolar or bipolar approach largely left to surgeon expertise rather than to disease complexity. And all that glitter is not gold, because I think QRP is not feasible in some situation. For large prostate, in case of stones, we see a lot of stones, maybe because the patient comes in our office more, when they are more older. And what about in those patients who used to take on chronic anticoagulant medication? So we have also to struggle with a lot of perioperative and postoperative complication on QRP. So transfusion rate is still up to 7.1%. And hematuria, clot retention, the need for transfusion. And look at the postoperative incontinence data. It is up to 40%, which I think it's a lot. I didn't expect that while I was preparing the presentation. Its QRP is 40% possibility of incontinence. And also we may experience complication like urethral stricture up to almost 10%, and bladder neck contractures, again, up to almost 10%. So TURP remains the historical benchmark because it's widely available and reproducible, but its limitations are well known: bleeding, incomplete tissue removal, and reduced durability in larger glands. So over time, multiple alternatives have emerged, not to replace TURP overnight, but to address specific unmet needs, such better control of the hemostasis, true anatomical removal of the tissue, and scalability with prostate sites. So among these options, enucleation represents a conceptual shift because it goes from resection to complete adenoma removal, while other ablative or non-ablative techniques mainly aim to symptom control rather than anatomical correction. So open simple prostatectomy is an option. It's still a valid option for larger prostate, but with several issues. So longer catheterization and hospitalization time, transfusion rate, urinary incontinence, and so on. Robotic-assisted simple prostatectomy may represent a minimal invasive approach. I disagree a little bit with that because I think that if we can manage the procedure endoscopically, that is the way, instead of going trans-abdominal for kind of procedure like this. And it also depends on the availability of the robotic platform. We have to struggle with cost. So I want to consider still RASP like a procedure under investigation, and we also lack of a adequate randomized control trial. So, although MIST can be appropriate in selected cases, the ideal candidate for these procedures is not really clearly defined. So despite some symptomatic relief and only minimal improvement in urinary flow, you know that the flow may increase of 4 or 5 milliliters per second, even sometimes a little bit more, but it's not a real disobstruction, And they do not provide a true and durable relief of bladder outlet obstruction. So this is exactly where laser enucleation comes into play. It's a technique capable of providing complete anatomical enucleation, durable obstruction relief, and reproducible outcomes across all prostate sites, something no other minimal invasive option have been able to match. So holmium laser was the first introduced into clinical practice in 1995, and over the past 30 years, several other laser platforms have entered the market. They introduced advanced pulse modulation, greater wavelength stability, higher energy efficiency, and more controlled tissue interaction, enabling finer and safer anatomical plane dissection. So in our center, I personally perform more than 500 procedures for BPH during the year, and nearly 90% are laser enucleation. So we routinely work with the major laser platform. So I have all the kind of holmium laser, pulse thulium, the TFL, real pulse. And however, today I will focus mainly on HOLEP because I think it is not the only option that we have, but it is currently, I guess, the technique supported by the strongest and most mature body of evidence in literature. And so how holmium works. So the holmium laser generator used solid-state holmium YAG crystal pumped by high-energy flash lamps to produce coherent light at a wavelength of 2.1 micrometers. The energy is delivered in a short, high-power pulse through a fiber, where it is absorbed by water in the tissue, creating precise photothermal fragmentation and dissection. So both AUA and EAU guidelines now recognize HOLEP as a prostate sites independent option for the treatment of LUTs related to BPH, with a moderate recommendation in the United States and a strong recommendation in Europe. What is, I guess, particularly relevant is that HOLEP spans the entire volume spectrum, from small to very large prostates, positioning enucleation as the most versatile surgical strategy. And this reflects a shift from technique-based selection to anatomy-based surgery. And why we should prefer holmium laser enucleation? We have high-quality evidence in literature. Is, as I said, versatile, not only for regarding prostate sites, but also because we can treat both BPH and stones. It fits, as we already said, all prostate sites, fits all the technique. We can perform one lobe, two lobe technique, en bloc, ejaculation sparing procedures. We can modulate the power, and nowadays we can modulate the pulsation. So these are all the reasons why I think that HOLEP is the new gold standard in BPH surgery. We have several publications comparing HOLEP versus TURP. This is a meta-analysis of 13 randomized controlled trials, and the conclusion were the HOLEP group had better IPSS and PVR and fewer postoperative complications than TURP in terms of hemorrhage, control of the bleeding, transfusion rate, clot retention. The operating time was quite longer, but it is mainly related to the steep learning curve, and we will talk a little bit about it. It allows for more complete and superior tissue removal and a shorter postoperative irrigation, catheterization time, and hospital stay. And results remain durable over the years. So it is also superior in controlled bleeding. So superior outcomes are also preserved in patient receiving anticoagulant therapy. So this is something very important. Maybe I think 40 up to 50% of the patients that I see are under chronic anticoagulant therapy. And also, HOLEP enabled through anatomical enucleation, resulting in a significant larger amount of tissue available for histological analysis. And I think this is very important. This translates into a higher incidental prostate cancer detection rate compared to TURP, and often underestimated but clinically relevant advantage. And in elderly patients also, HOLEP offers a safer perioperative profile than TURP, with faster recovery and fewer complications. So this is a key advantage in a frail population. So these are two pretty famous tennis players in Italy. You can see in the upper part of the slide, Sinner, and in the lower part is Adriano Panatta. No one of you know Panatta. I'm Italian, and I know him. He was a champion during the 60s. But these represent exactly what I feel when I think about HOLEP and TURP. So Panatta represents the classic game, is elegant, effective, but built for a different speed and a different context. As Sinner is the modern player, so he has power, precision, and endurance, and a game designed for today's court. And TURP and HOLEP follow the same identical logic in my mind. So TURP is a kind of dinosaur. It's reliable, historically important, but limited by its design. HOLEP is the kind of alien, so it's anatomical, it's scalable, and is built for the complexity and expectation of modern BPH surgery. So there are several holmium laser platforms available on the market, and choosing among them is not straightforward. Differences in pulse modulation, energy delivery, and system ergonomics can influence surgical feel and efficiency, and even within the same laser family. So I really think at the end that the selection of the lasers should rely only on personal preferences and experience. One of the things that I want to address is that the systems are relatively delicate. So the choice should also take into account the availability of a strong and responsive technical support service. And this is the technique that I use as an inverted U at the apex of the prostate around the verumontanum. Then we perform the 5 o'clock incision in the posterior part. Then we proceed with a 12 o'clock incision in the anterior part, and then we proceed with the left lobe. And in case of third lobe, we do all together the third lobe and the right lobe. So this is a short video. So this is I don't want to show you the whole procedures because I know it's boring, but what I want to just show you is the most crucial part of the procedure. So to find the right anatomical plane between the adenoma and the peripheral part of the prostate. So I personally use a very low power energy, around 60 watt. And then I try to identify the plane. And then I use the fiber as a small finger to help me identify the plane. So this will not burn the tissue, and I can easily recognize a different color between the adenoma and the prostate. As you can see, I use like very small finger. Control of the bleeding is very easy and meticulous. And I try to identify the plane on both sides of the verumontano, which is the easier part to find the plane. And you see, when you find the plane on the posterior part, it will become easy. It's not always like this. Sometimes we have prostate with a lot of inflammation, so it's hard to find the plane. But once you have, you gain more experience, you're gonna find it easily. You see, we proceed, we gently push the tissue. Control the bleeding, very easy. Okay, I think we can move on. Okay, this is the morcellation time, which I think is the hardest part of the procedure, especially at the beginning, because you are afraid of making a hole in the bladder. And you don't have to be, I think we have to respect some rules. First of all, you have to have a very clear visualization of the field. So you don't have to have a bleeding in that moment, because this will impair the ability of your morcellation. So it is very important. We have some rules, as I was saying. So control the bleeding before. If you need to use your resectoscope and have a better visualization of the field, it doesn't matter. It's not a shame, to take the resectoscope and better control the bleeding. Then you have to have a full field bladder and keep the spaceman in the middle of the bladder. And then what I think is crucial is to have the best morcellator on the market. I have all the morcellator on the market. I cannot tell you which one I prefer on the podium, but if you want to talk later on, I can tell you everything about the new morcellator system. What I prefer is always the one that goes east to west, not north to south, okay? Just lateral morcellator. It's gonna take, if you have the right instruments, it's gonna take just a few minutes, okay? And you will not lose your specimen while morcellating. Okay, we can move on. Just a few words about pulse modulation. You know the system, it delivers pulse into different peaks. The first one separates the water and creates the bubble, and the second one delivers the energy straight to the target. This will translate into increased efficacy, higher precision, and optimal energy delivery. We already have literature on this pulse modulation system, and this is a meta-analysis on 7 studies, and the results say that MOLEPs perform better in terms of intraoperative outcomes compared to traditional HOLEP. We improved the intraoperative hemostasis time, enucleation time, and overall operative time. So nowadays we have different pulse laser on the market. The new Pulse Thulium Challenge holmium YAG, not by changing the concept, by refining energy delivery and different laser, but with the same goal. So the quality of anatomical endoscopic enucleation matters more than the wavelength. And this is an example for the new real pulse thulium laser. We can reach a peak power up to 3.700 watts with the frequency up to 300 hertz. So this is just to show you that if you don't see what kind of laser it is, and you don't know the brand, you will not see any difference, okay? So basically, at least they are at the same level of quality in terms of dissection of the tissue. I would say that the new real pulse maybe may have, in my experience, a better control of the hemostasis because of its physics. So what are the challenges in the widespread adoption of the technique? Of course, it has a steep learning curve. And a mentorship program is of paramount importance. What I suggest is when you plan to buy a laser, don't buy just a laser. Try to buy the entire, mentorship program together with the laser, because at least you need 20 cases in a short time frame just to understand how it works. And then you need to have someone that give you, the ability to operate and stay calm. Don't be in a hurry if you don't find the plane, someone that may help you. Sometimes it may be a very, a nightmare. I do perform a lot of robotic procedures. I do perform hundreds of partial nephrectomy, but to me, I have to struggle sometimes a little bit more with large prostate with a lot of inflammation due trying to attempt an enucleation more than a large renal tumor. So why? I was saying that the surgeons are afraid of causing sphincter damage, especially when you are at the apex in large prostate. You may lose the plane, you may struggle with bleeding and hemostasis control, and you have to know the technique for a proper morcellation. So what are the conclusions? So laser enucleation of prostate nowadays should be considered the gold standard of surgical treatment for BPH. Laser selection depends on several factors, especially surgeon preferences, endoscopic experience, and economic resource and availability of an assistant service. Results are strongly related to an effective and well-structured proctorship program. If possible, choose a high-power laser with pulse modulation, since this technology has shown to improve intraoperative outcomes. And new thulium pulse laser are competitive with the holmium laser. No significant differences up to date, but literature is still premature. So how many of you are thinking about switching to laser enucleation? No one? Please, you have to raise your hands. Otherwise I fail. Okay, thank you. Thanks for your attention.